Good afternoon, Arjun. Arjun is going to give an introduction on topographic overview and Ectasia, how to manage and how to make a diagnosis based on the topographic findings. Over to you, Dr. Arjun.
Thank you, sir. So this is my humble attempt to give you an overview of topography within the next 8 to 10 minutes. So corneal ectasias can, as you know, definition is non-inflammatory progressive, the hallmark being a steepening and thinning of the cornea. There may be the types, it may be a primary or a secondary, the primary being the keratoconus or PMD, the secondary being the post-LASIK versions. And it may be, you can define as central or the peripheral ones, the peripheral ones being the PMD, the terians and the PMD like KC. So ectasia mostly is bilateral but is mostly asymmetrical. And topography has been the gold standard in evaluating any ectasia and also understanding the progression. It has even the topography has evolved from the Placido's disc all the way to the present generation ASOCT devices. So the basic principle remains the two, the reflection based and the Scheimpflug based or elevation based, which includes the Scheimpflug or the ASOCT based devices. So in the reflection based devices, you have a calibrated Placido disc which is projected onto the cornea. The reflected image is then digitized and calibrated based on the size of the image and the size of the disc which is projected. You get the keratometric power for the individual location and the maps are created. In slit scan technology, you project a slit onto the cornea, and after the slit is reflected back, individual points are calculated by what is known as triangulation. That is solving a triangle. If you know the distance between the camera and the eye and the reflected light angle, you will get the point-to-point values. So going on to the Scheimpflug principle, if the image plane and the lens plane is parallel, then the the object plane and the lens plane is parallel, the image will be quite clear. But in our case of cornea, it is not parallel, it's a curved surface, so it will cause distortions. So in such a case, by distorting the plane between the object and the lens, you can get a much clearer image. This is something which we intuitively do when we take a selfie, that we either tilt our head or the phone to get a better image. That is the simple principle of Scheimpflug. So the prototype device in this case is Pentacam, which takes multiple images, and from these images it finds the shape of the cornea. In other words, here the elevation is determined first, then subsequently the power is calculated. In other devices, the power was calculated, from the power they determine the shape. So any of the topographic maps will have the chord maps, which includes the anterior elevation, posterior elevation, the corneal thickness, and the keratometric or the power maps. So going on to it, first understand your parameters, the color conventions. The cooler colors will show lower areas, flatter areas, or thicker areas in the respective maps, and the warmer colors will show higher, steeper, and thinner areas. So on a cursory note, these two eyes may look similar, these two maps may look different, but as the same eye. Only thing which is changed is the scale. The first one is an absolute scale, where every time the map is, the keratometric power has the same color convention, but the next is the relative one. In the relative one, the machine determines the lowest power of the eye, highest power of the eye, and then redesigns the map. So absolute, it is easier to compare between visits, compare between eyes, when the color coding is always the same. Again, this is another thing you have to see, the gradient of change. This is same eye, but the gradient changes, the steps have increased, either 0.5, 1 or 2. As you can see, when it becomes 2 or when it's more lax, the details and the patterns start disappearing. In other words, even an abnormal eye will start looking normal. One more thing you can change in present generation devices is the diameter. This becomes important when you're dealing with a peripheral ectasia, because in such cases you require more than 8 mm, 12 mm maps to identify the peripheral thinning as well as the peripheral keratometric powers. So this is the overview you have to see. And now you can go for interpretation. But before you interpret any patterns or parameters, you should understand your reference. The reference commonly used was the best fit sphere. The newer devices have the other references like best fit toric ellipsoid or best fit ellipsoid, toric ellipsoid fixed, etc. So understand the reference before you interpret the parameters. So in the keratometric map, one more thing you have to see is the strategy used. Just a brief overview, the two strategies you can use is the sagittal or the axial map or the instantaneous or the tangential map. In an eye like this, there are subtle areas of elevations, and when you try to take a map out of it, your axial map will only generalize the whole map, but it will not show you the subtle variations. So you have to find out the tangential map in which the subtle variations are represented by the different radii of curvature. In other words, to get a general overview, you can use an axial map. To find out surface variations, you can use a tangential map. Finally, going into the patterns, you have the commonest 10 patterns in the holiday. In the maps, it will look like this. You have the circle, the oval, the inferior and superior steepening, the bow ties, which may be symmetric, asymmetric, or with skewing or without skewing, and last is the irregular pattern. There are some specific patterns like this, the butterfly, crab claw, or the vertical D. This commonly occurs when the ectasia starts moving away from the center, which produces a phenomenon known as the loop cylinder. As the ectasia further moves away, the loop starts coming into picture, and the butterfly starts to look like a vertical D. So this is more seen in peripheral ectasias. So again, you have to see the ocular surface. Sometimes the dryness, even scar and previous surgeries will induce a topographer, and you will get an irregular pattern. One more aspect is in any topographer, the astigmatism is represented by the bow tie or two ellipses. If it's a regular astigmatism, both the ellipses will be in the same radial axis, but if it is irregular, one of the ellipses will start deviating away from it. This is known as a skewing, and the amount of deviation will give you the idea about whether it's significant or not significant. This month we have lost many veterans in ophthalmology, and one more person we lost, and you can't say topography without saying the word Rabinowitz. So this month he passed away. So we have all these criteria which I said are part of the Rabinowitz criteria. So going on to the map patterns, one of the patterns you have to see for is an asymmetric bow tie with skewing of the radial axis, because this can happen only in 0.05% of normal population. If you see this, you are more likely dealing with the ectatic person. Going on to the parameters, I'll try to cover both the devices at one go. I apologize for doing this. So keratometric map, one thing you have to see is the Kmax. The Kmax, if it's less than 47.2, it is normal. More than 48.7 is mostly abnormal. And next you can see is the posterior best-fit sphere. That is the power of the posterior best-fit sphere. Less than 52 is considered normal. More than 55 is considered abnormal. You can also take the ratio between the anterior and posterior. So this is one of the Escarpate's criteria, where the value less than 1.2 is normal, more than 1.27 is considered abnormal. And keratoconus mostly is an inferior steepening. So if there is a difference between the inferior and superior powers more than 1.5 diopters, it is considered significant. And when it becomes superior inferior steepening, it has to be more than 2.5 to be considered significant. So going on to the elevation maps, before you see the maps, you can see that based on the best-fit sphere, some part will be above it, which will be represented by the warmer colors, and some part will be below it, which will be represented by the cooler colors. So if there is only a uniform power with the central elevation, you will get an island, and if there is an astigmatism, you will get an hourglass kind of pattern. Again, you have to see for the reference use. This is the same eye. One is the best-fit sphere, the other is best-fit toric ellipsoid. The best-fit toric ellipsoid helps you identify the cone location. It's more sensitive in finding out the subtle changes in the eye. So again, the criteria, anterior elevation more than 40 or a posterior elevation more than 50 is considered abnormal. If you see this caricature here, some areas are above the best-fit sphere, some areas are below the best-fit sphere. So the difference between the highest point above and the lowest point below should not be more than 0.04 mm. If it's more than 0.05 mm, it is considered abnormal. Again, you have to also see for the reference used before you use the values. In case of BFS, a value of more than 8 microns or 18 microns for posterior, and in case of toric ellipsoid, 12 and 15 respectively are considered as abnormal, depending on the whether it's myopic or hypermetropic. So for the pachymetry map, the pachymetric map helps you identify the central area, which is the most thinnest where the cone is likely to locate. So in this map also, you have to see for the values anything more than 500 is usually normal, less than 470 is abnormal. Another thing you have to see is the change within the map. That is, the 7 millimeter zone is compared to the thinnest location. There should not be a difference of 100 between these two locations. And another thing is, mostly our cornea, the central area is the thinnest. If there is a difference between the thinnest location and the center by 30 microns, it is considered abnormal. One more thing you can see for this, the y coordinate. Y coordinate is the inferior deflection of the cone. As I said, most of the ectasias are inferior and temporal. If the y coordinate is more than 1 millimeter from the center, it is considered abnormal. Just an overview, this is a typical keratoconus map with the steepening within the keratometry map, elevation corresponding areas, and the thinning. And in this map, if you cursorily see, it will look like a crab claw or a butterfly effect. But if you see, there is no inferior elevation. The steepened area or thinned area is in the center. This is a PMD-like picture in KC. And this is the typical against the rule astigmatism with the inferior thinning and elevation in case of a PMD. And finally, this is one more thing you have to see. In case of the pachymetry map, you will see a pattern with inferior steepening, inferior thinning in the pachymetric map, which will look like a bell. If the map has that pattern, it's more likely to be a PMD. And this is one extreme case of superior PMD, where you can see the loop cylinder and also the inverted bell. The patient had extreme powers so that we could even visualize the angle structures without even a gonio. So this is last case where this is a child with both eyes very thin cornea, one eye developed eye drops. These are the keratoglobus and the brittle cornea patients. Thank you.
So nicely covered. It's a very volatile topic. You have covered it very well. Anybody in the audience, any questions to the speaker? Can you just sum up those findings, like which it is present, like you can say that it is keratoconus?
One thing which I completely skipped is, if with the pentacam, I can even use the Bellin-Ambrosio display also, which will give me a very clear idea regarding whether it is significant, the change is there. But mostly for progression and all, you can see the keratometric powers, the topography, the pachymetry, whether thinning is happening. Sometimes we will get a very thin cornea, but the keratometry may not change. So we have to also understand whether it's an astigmatism which is progressing along with the thinning. Then only you need to treat the patient. It may diagnose, you may end up with a form thrust, and there are topographers which will give you aberrations, which will give you a better idea, because sometimes aberrations happen first, then topography happens, then only refractive error changes happen. So patients seeing symptoms, maybe the aberrations are happening and their vision is dropping. But if you cursorily test with other devices, that will be missed. So it's slightly person to person, and if I have a pentacam, I would go with the Ambrosio display as well.
Thank you, Arjun.